So we didn't want this to be just giving you information, but really having you think about all the things that you see in practice every day that you struggle with and that we struggle with as clinicians. Even though we're statistically behind the curve here in Louisiana, we are really blessed to have wonderful practitioners and clinicians who stay at the forefront of what is happening, research, clinical, innovation, and trying to get the word out about what is available here in Louisiana for our patients can be rather hard. So I'm happy to have a panel of colleagues that are those experts, and we are going to go in the order of what is presented on the program. Hopefully these topics will spark some discussion. If you have questions, we're going to do panel questions at the end, so write your questions down, please. First up is Dr. Vera Hendrix. We unfortunately lost her to Yale School of Medicine last year, but she is the assistant professor of surgery. She specializes in breast surgical oncology. She is a member of the Center for Breast Cancer at Smillo Cancer Hospital. She completed her general surgery residency at Tulane and breast surgery fellowship at the University of Southern California, following her medical degree from Georgetown University. She is a distinguished scholar. She has advanced training in all of the oncoplastic surgical techniques and is known for her multidisciplinary surgical care. So she will talk to us about a surgical debate in our world as to whether we should be doing more or less when it comes to axillary surgery. Dr. Hendrix.
Thank you all so much for having me. Like Dr. McKinney said, I was here for 10 years throughout residency at Tulane, and I worked at Mary Bird Perkins Cancer Center for 3 years before taking a job closer to home in Connecticut. So I'm very happy to be back. I've only been gone 3 months, so it's nice because it's very cold in Connecticut. Yeah. And I'll be talking about axillary management, surgical management in CT1, 2, and 1 HR-positive, HER2-negative breast cancer. So that's a mouthful, and you'll hear me say it multiple times today. I have no relevant disclosures. Learning objectives that I hope we go over today are defining what sentinel lymph node biopsy is, what targeted axillary dissection is, and what formal axillary lymph node dissection is, comparing the oncologic outcomes, and discussing morbidity of each and quality of life implications. And then hopefully identify current guidelines and recommendations and what to look forward to in the future in relation to all this, and hopefully creating axillary management plans for that early stage hormone positive, HER2 negative breast cancer population that's getting upfront surgery with node positive disease. So this is Dr. William Halstead. He pioneered the Halstead radical mastectomy, which included axillary lymph node dissection. And basically, what an axillary lymph node dissection is you're removing level 1 and 2, sometimes level 3 lymph nodes during your surgery, and typically you're getting over 10 lymph nodes in your retrieval. And they were doing that historically as standard of care for staging and for local regional control. There was a lot of morbidity associated with axillary lymph node dissections. Lymphedema rates, which is the arm swelling, was upwards of 30%. You had other complications, including neuropathy, increased cost, chronic pain, reduced quality of life. So that's how sentinel lymph node biopsy kind of came into the picture over the last 30 years and led to a paradigm change. We were trying to do minimally invasive axillary surgery as a staging approach. Using dual tracer, we had low false negative rates, and we reduced morbidity of axillary lymph node dissection. Then came about targeted axillary dissection, or TAD, and that's historically used in patients who had node-positive disease. They were getting neoadjuvant chemotherapy, and they converted to node-negative, or they had a PCR in their nodal, they had a nodal response. And so in order to do this targeted axe dissection, those patients had a biopsy placed at the time of their pre-op consult. They had a localization, and then they had a sentinel lymph node biopsy as well. And this showed low false negative rates, and this became acceptable instead of offering those patients who converted to N0 a formal lymph node dissection. So lymphedema comparison rates between all three, as I mentioned, axillary lymph node dissection is 30%, sentinel lymph node biopsy and TAD around 5%, and then a significant quality of life benefit with sentinel lymph node biopsy and target axe dissection. So these, in general, were the indications for axillary lymph node dissection in upfront surgery if a patient had over a 5-centimeter tumor, matted or fixed lymph nodes, palpable lymphadenopathy. In NSABP B18, 28% of patients had 4 to 9 positive lymph nodes, and 23% had over 10 positive lymph nodes if they had palpable lymphadenopathy. Indications for axillary lymph node dissection in the post-neoadjuvant setting are if patients are the size criteria of T4, matted or fixed lymph nodes, if they only had 1 to 2 sentinel lymph nodes identified and they didn't obtain that previously biopsy positive clip node, the false negative rate was extremely high, upwards of 24%. So that also entailed performing an axillary lymph node dissection. And then, of course, if palpable lymphadenopathy persists after neoadjuvant chemo. And then all patients with inflammatory breast cancer also had axillary lymph node dissection. So in summary, all clinically node-positive patients historically required a formal lymph node dissection. There was de-escalation through the use of sentinel lymph node biopsy and TAD, particularly in patients with clinically node-negative, limited nodal disease, so only 1 or 2 sentinel lymph nodes positive that were getting upfront surgery, and then adjuvant systemic treatment and radiation. And then also in the setting of node positive that converted to node negative with neoadjuvant chemo. But what about the node positive patients that are HR positive, HER2 negative? The management of that is very complex, it's evolving, and it's complicated because most of those patients don't respond to neoadjuvant chemo, and they have low nodal PCR rates, less than 20%. So this is the NCCN guidelines, and you can see outlined in red are for patients who have clinically palpable lymph nodes. They get a biopsy, it comes back positive, and they're not getting preoperative chemo, so they're getting upfront surgery. Those patients typically will get an axillary lymph node dissection, even if they have limited nodal disease. If you look at the second line where it says no palpable lymph nodes, but axillary suspicious imaging and maybe 1 or 2 lymph nodes that are biopsy positive, they can undergo a lymph node biopsy. So that's the difference between image detected suspicious lymph nodes that are biopsy proven and palpable lymph nodes biopsy proven. And they have 2 different managements. So this just goes further into de-escalation of axillary surgery. On the left side, we had axillary lymph node dissection where we took a multitude of lymph nodes, and then we had a lot of landmark trials, including Z11, Amaros, Cenimac, that showed that we can do sentinel lymph node biopsy in clinically node-negative patients, and we don't have to go on and do a completion axillary lymph node dissection if they had only 1 or 2 lymph nodes positive. And then the far right pictures, targeted axe dissection, that talked about clinically node-positive patients converting to node-negative after neoadjuvant chemo. These are just the clinical trials more in depth, and whether they randomize patients to sentinel lymph node biopsy or axillary lymph node dissection or axillary radiation therapy versus axillary lymph node dissection. So all of these landmark trials omitted axillary lymph node dissection as standard of care for the clinically node-negative patients getting upfront surgery, but they excluded clinically node-positive N1 patients. So if you remember the NCCN guidelines, that top line is extrapolating from these clinical trials like Z11 and Amaros criteria, T1 to clinically node 0, undergoing upfront surgery with very limited sentinel lymph node positivity, and they're putting it towards technically CN1 patients. This slide is just a summary, and it goes into the novel technique now, which is targeted axillary surgery. And that I'll talk a little bit about in the Taxus ongoing clinical trial that came out, that started in 2024. So, in summary, clinical node positive breast cancer management, like I said, CN1 is technically defined as image detected or palpable lymph nodes. Upfront surgery is possible in select hormone positive HER2 negative breast cancer because of that low rate of nodal PCR. If they don't have a PCR after undergoing neoadjuvant chemo, usually they will get a axillary lymph node dissection. In the neoadjuvant chemo setting for node positive breast cancer, usually HER2 positive and triple negative will all get neoadjuvant chemo. And then in terms of hormone positive HER2 negative, it depends on other factors. So our exponder was addressing the ability of a 21 gene recurrence score to predict survival benefit from chemotherapy in patients that had 1 to 3 positive lymph nodes, so N1, with hormone positive HER2 negative breast cancer. It randomized 5,000 women with T1 to T2 tumors and a recurrence score less than 25 to endocrine therapy or chemotherapy in addition to endocrine therapy. And it showed that there was no survival benefit in the addition of chemotherapy to endocrine therapy in postmenopausal women. So if you extrapolate that, you can think that the use of neoadjuvant chemo for axillary downstaging alone is not warranted, for example, in that population I had just mentioned. Systemically, Monarchy was another trial that looked at kind of more compelling evidence towards doing more axillary surgery. It randomized 5,000 women, high risk, with hormone positive, HER2 negative patients to get adjuvant endocrine therapy alone or with a CDK4/6 inhibitor, abemaciclib, along with the endocrine therapy. And it basically showed a significant disease-free survival with the addition of abemaciclib to endocrine therapy. So there were concerns about undertreatment among those patients that had a low oncotype score who may benefit from chemotherapy only based upon nodal disease. Then the NATALEE trial came out, and that was looking at ribociclib plus endocrine therapy, and that showed basically it was applicable to node negative and node positive patients. And so in turn, systemic decisions should be based on nodal information that you have available and try to avoid unnecessary axillary lymph node dissection. This is the ASCO guidelines from 2025, and if you look at the outline box here, you can see clinically node positive patients that are going upfront surgery. The standard of care is axillary lymph node dissection. But which patients with hormone positive, HER2 negative, CN1 breast cancer can we safely limit axillary surgery? So these are 3 studies that actually showed 50% of CN1 HR positive, HER2 negative breast cancer have only 1 to 2 lymph nodes that are positive. If upfront sentinel lymph node biopsy is standard of care for CN0 with 1 to 2 positive lymph nodes, can upfront TAD be applied to CN1 patients with a limited nodal burden, less than 3 lymph nodes? And so this just showed some of the predictable factors of what could cause a patient to have higher nodal burden, like a higher T stage, so a larger size of their tumor, was a predictive factor in most of the studies. This also shows these other significantly associated factors of having a higher nodal burden of 3 or more positive disease. If a patient was less than 60, if there was lymphovascular invasion, if there was a history of recurrence, a mastectomy, the larger tumor size that I mentioned, and then a shorter tumor to nipple distance was also important. This is the TriNet-X study. It was a US collaborative network retrospective study that looked at 140 million patients across 106 healthcare centers, both academic and community. The inclusion criteria was anyone over 18 with CN1 disease, hormone positive, getting a sentinel lymph node biopsy versus an axillary lymph node dissection, and it showed the 10-year overall survival was equivalent between those with CN1 disease getting a sentinel lymph node biopsy or an axillary lymph node dissection. This is the TAXUS trial. It's an international randomized controlled trial of patients with node-positive breast cancer, either undergoing neoadjuvant chemo or upfront surgery with the targeted axillary surgery, the TAS, which is that new novel term, and they were randomized to completion axillary lymph node dissection or axillary radiation therapy. And so there was a cohort within this study that was a prospective observational cohort that actually underwent upfront surgery, and you can see on the bottom they either underwent axillary dissection or axillary radiotherapy, and so the data is still ongoing because they're still recruiting, but you can see in the upfront surgery group the factors that were associated with additional positive lymph nodes on axillary lymph node dissection was the number of positive nodes they had on TAS, and if there were palpable lymph nodes to begin with. MD Anderson did a retrospective single institution study looking at patients between 2001 and 2021 that had upfront surgery with axillary lymph node dissection. They all had positive axillary ultrasounds and biopsy-proven nodal mets. If they had more than one suspicious lymph node on axillary ultrasound, that was most predictive of having a higher nodal burden, and 30% with one suspicious lymph node had greater than N2 disease. So they concluded that pre-op imaging, including axillary ultrasound and MRI, can predict the evidence of nodal mets, but it's inaccurate in letting us know the extent of the nodal burden. This is another NCDB analysis that showed kind of 5-year overall survival rates between sentinel lymph node biopsy and adjuvant radiation versus formal axillary lymph node dissection in our patient population that we're looking at getting upfront surgery between 2010 and 2016. And it showed that there was a similar overall survival, so kind of favoring less is more. There are 3 prospective randomized clinical trials that are ongoing right now at MD Anderson, MSK, as well as the TAXA study I mentioned, looking at the accuracy of doing upfront primary TAD in our patient population. So there are some preliminary results from the MSK prospective trial. They had 78 patients with T1-2 size, hormone positive, HER2 negative, CN1 positive, and they actually just did palpable positivity, not just image detected. And on axillary ultrasound, they had to have less than 3 abnormal or suspicious lymph nodes. And these patients had upfront surgery and a sentinel lymph node biopsy. They were randomized if they only had 1 to 2 positive lymph nodes to no completion axillary lymph node dissection. And if there were greater than 3 positive lymph nodes, they had a formal completion axillary lymph node dissection. In their relatively short follow-up, which is less than about 12 months, they saw no isolated axillary or local regional recurrences. So in summary, the MSK trial actually, the preliminary data supports use of upfront sentinel lymph node biopsy or TAD in our patient population as long as they're getting pre-op axillary ultrasound, and it showed that it avoided axillary lymph node dissection in 70% of patients. You did have to remove the palpable lymph node during your sentinel lymph node biopsy. That was one of the main criteria. And it also minimized the morbidity that we all know of axillary lymph node dissection. But we do need more long-term follow-up to determine the local regional failure rates. So if you are a breast surgeon, you know that the American Society of Breast Surgeons is basically our Bible. So I had to include a slide from their most recent resource guide in 2026 looking at axillary management. So the top one is kind of referring to that NCCN chart that I showed previously. But if you had a clinically node negative, palpably node negative patient that had abnormal suspicious axillary imaging and or a positive biopsy, you could technically do a sentinel lymph node biopsy, and they showed that 50% of those patients with a positive lymph node on biopsy only had 1 to 2 positive sentinel lymph nodes, and they avoided axillary lymph node dissection. In the second point, in clinically node positive, palpably node positive patients, biopsy proven that were getting upfront surgery and ineligible for neoadjuvant chemo, axillary lymph node dissection was the appropriate care. And that's because the palpable lymphadenopathy, usually those patients had higher volumes of nodal disease. So in final conclusion, CN1, hormone positive, HER2 negative breast cancer, we all know neoadjuvant chemo is suboptimal, low nodal PCR rates less than 20%, rare axillary downstaging, 80% will end up with an axillary lymph node dissection and possibly lymphedema. The S2206 study is ongoing, and it's looking at mammoprint high risk 1 patients getting upfront surgery. So that's something we will have more information as it comes about. Upfront TAD in select patients with limited nodal disease burden may prove to be a better option and have less morbidity and similar oncologic outcomes as formal axillary lymph node dissection, but we need accurate pre-op imaging, and we need intra-op consistency because it's very subjective between when surgeons are doing sentinel lymph node biopsy, target axis dissection, and this novel TAS, target axillary surgery. And of course, we have to have multidisciplinary tumor board discussions and consensus with everybody, because when the breast surgeon de-escalates something, the radiation oncologist or the medical oncologist may not be able to de-escalate in their area. So we have to have a tailored approach to each patient in each case. Thank you for allowing me to speak on this topic. I look forward to any questions. This is my daughter. She's 3, and she always hears mommy is going to clinic or to surgery, so this is her version of going to surgery in her Disney princess dress with her dolls and her grandfather escorting her out. So it just shows you anything's possible.